Hey team, Raphael here with Ask Me Anything for the week of 17 July 2020. I've got a bunch of questions, so let's get into it. Susan asks, not sure if you said this, but do disc bulges calcify? And Susan, the short answer to that is yes, they do. Calcification is a process that's pretty common, happens in many body tissues, and essentially we have calcium salts dissolved in all of our body fluid, so our blood and our interstitial fluid that's outside of the circulatory system. And we need calcium. We have multiple redundant systems in our body, all designed to maintain our calcium levels. So the level, the concentration of calcium that is dissolved in our body fluids at between a very specific range. And that's because essentially calcium is critical for multiple functions in the body, particularly muscle contraction. So when you think of muscle contraction, in order to initiate the muscle contraction, we need calcium. So and essentially almost everything we do is muscle contraction. So not just movement, but your heart is a muscle. Breathing is a mechanical act initiated by muscles in your torso. Digesting food, your digestive tract is a muscle. Your blood vessels, your veins and arteries are muscles. So pretty much anything that you could do requires muscle contraction, and all muscle contraction requires calcium. So no calcium, no heartbeat, no digestion, no breathing. So calcium's kind of a big deal, and we maintain our blood calcium levels at very particular level. So there's always calcium floating around in your blood, in your interstitial fluid. That's the fluid outside of your circulatory system. And from time to time, that calcium, it's dissolved in your body fluids, but from time to time it can crystallize, and it can crystallize in tissues, like it commonly crystallizes in tendons or ligaments, and it can crystallize in muscles and also in discs. So when it crystallizes, it literally forms a crystal, like a crystal of rock salt or something that you buy from the supermarket. And does it cause a problem? Well, it tends to cause somewhere between no problem and significant problems, depending on where it is. So a lot of tendons have calcification in them, and that can cause kind of creaking and cracking and crunching and stuff as those tendons move. The little crystals, like think of a rock salt crystal, kind of crunch over the bone underneath it or the tendon it's sliding across or whatever, and cause kind of weird and wonderful sounds. But that generally doesn't cause any actual problems, just kind of a weird noise. Whereas calcification in herniated discs is associated with greater pain in the short and medium term, but in the long term, no greater pain than people without calcification in their herniated discs. So short answer is yes, herniated discs can calcify, and that is associated with slightly increased pain in the short term, but in the long term, no difference. Magali asks or says, thanks, Raphael, for another super interesting session. I've done anatomy courses in other places, but I find your explanations the most detailed and easy to understand, as I'm fairly new to this fitness world. There's one thing I would like to ask you. When you talked about the fracture of the vertebral endplate, you mentioned avulsion as another possible result of high compression in neutral. Avulsion means that a part of the bone breaks and separates from the body of the vertebrae. Did I get it wrong? Thanks for your patience and great work. Well, thanks a lot, Magali. Appreciate it. Let's have a look at what avulsion is, and you're exactly right. Avulsion is a possible injury that you can get to your endplate in neutral spine when you compress the spine. So let's have a look at the basic anatomy here. All right, so let's do a cutaway view of a vertebra. So like we've chopped the vertebra in half from top to bottom, and we're looking at the slice. Okay, so there's your two vertebra, and then we have a disc, and a disc of a vertebra is a structure. It's basically a ligament. It's made of multiple layers of concentric ligaments, so about 20 layers, and they kind of look like this. That's basically what they look like. Those go around there. And if I draw this out even better, what you'll see is that this outside of the vertebral bone here, so this vertebral body, this main part of the vertebra, the outside kind of couple of millimeters of that is composed of this thick, rigid cortical bone. So that's called cortical bone. And a cortex is just something that's on the outside. So you have a cortex in your brain, you have cortexes in your kidneys. Cortical bone is just the bone that's on the outside, and that is tough and rigid. That's when you look at the outside of a bone, that's what you see is the cortical bone. And on the inside of the bone, we have these trabeculae, which are lined up along the lines of force that are transmitted through the bone. And trabeculae, let's write that out. Trabeculae, that's the plural, and a trabeculum or a trabecular means a beam. Means a beam in Latin. So basically these are, think of them like scaffolding beams that we have inside the bone, and they serve two purposes. One is to give strength to the bone without giving a lot of weight to it. So we have these sort of reinforcing scaffolds inside rather than a solid structure. And the second reason is that they leave space in between, which allows us to use that space for other stuff. And one of the most important things that happens in the spaces in between the trabeculae is we manufacture our blood cells. So that is what happens in the bone marrow. And the trabeculae give the bone quite an enormous amount of strength without giving it a lot of weight. And I've drawn them all 100% parallel here, but you'll also have, ones going across. Depending on what forces the bone is subjected to, the trabeculae will line themselves up along the lines of those forces. And then we have the disc. And so this outer part of the disc, the wall of the disc, is called the annulus. Fibrosus. And annulus just means ring, something that is ring-shaped, and fibrosus just means fibrous. So this literally means the fibrous ring, and that's what it is. It's a ring of tough fibrous tissue. And then on the inside we have the nucleus pulposus. And nucleus means the seed, or the middle bit, the bit that's in the middle. And pulposus just means pulpy or soft. And so the nucleus pulposus is the soft middle bit. So we have our, and that is because it's mainly water. It's a fluid. And it's got some other things floating in it, a few proteins and sugars and things like that, but basically it's a liquid core. And so that's the cutaway side view of a pair of vertebrae and a disc. Now let's have a look at how that functions, that's the anatomy. Let's have a look at the biomechanics of how that works under compression. All right, so when we have, in fact, let's look more closely at the end plate. My apologies. So I drew the vertebra kind of like that, and I drew the end plate and the disc, kind of like that. Okay. And this region here is called the endplate, the vertebral endplate. And that region there it's neither wholly bone nor wholly disc. So what actually, if we could zoom in with, say, an electron microscope at that area, what we would see would be some fibres of disc, and these would be, in fact, let me draw them straight because that is how they would be. Fibres of disc, and those would be collagen fibres. So those are collagen fibres. And collagen is a type of protein that is pretty straight and rigid, and we use it throughout our body to give structure to parts. And then we would see up the top here these trabeculae. And so this part is the disc, and this part is the vertebral body. And then this part in the middle is the end plate. And what we see in the end plate kind of transitional structures there. So what a trabeculum is a calcified collagen fibre. So it's just collagen with crystallized calcium on it. And so what we would see if we could zoom in here with an electron microscope would be sort of this transitional zone, which is, called the end plate, which is neither purely a ligament, like the disc here is, nor is it purely bone like the vertebral body is. It's kind of bony ligament, a ligamentous bone. It's a transitional scenario. So, and that's the same anywhere that two tissues in your body join together. So if you have a ligament that joins a bone, or a tendon that joins a bone, or a tendon that joins a muscle, it's not kind of glued on as such. The two tissues blend into each other, and it's continuous tissue. So anyway, that is the end plate. And so that is why I drew the end plate going up into the vertebra. Now let us look at the forces on such. All right, so you've got your vertebra here. You've got your vertebra here. And you've got your disc. And I'm just going to draw this cutaway like this. For reasons that will become apparent very soon. And here is the nucleus pulposus. Okay, and this part here is the annulus. All right, and so now let us put a compressive force on this. Okay, so now we're pushing down on that. So now let me push down on that, and let me see if I can I can push that down a bit. Oops, wrong one. That's the one. Okay, so now when we compress that, the vertebra gets pushed downwards and it squishes, compresses, because compression means squishing. That the high-class word is compression, the low-class word is to squish. It squishes the nucleus pulposus and it makes it shorter. So there's a compressive force that is transmitted down through the vertebra into the nucleus pulposus. Now, the nucleus pulposus is mainly comprised of water, and one of the things about water is it is not compressible. Water is not compressible. So you can't make it smaller. You can't make water smaller. What you can do, it is deformable. Water is deformable. You can make it a different shape, but you can't make it smaller. So what happens when you try and compress water? Like imagine if you had a hot water bottle and you sat on it. You know, you wouldn't make it smaller, but you would make it spread out. So what happens is this nucleus pulposus got shorter, and at the same time it got wider. It gets wider. So now it spreads out because it still takes up the same amount of volume, the same amount of space. And so what that does is that creates, that pushes outwards, that creates a force that pushes outwards on the annulus fibrosus. Okay. And what it does is that tends to make the annulus fibrosus kind of stretch and curve out like that. And the annulus fibrosus can take that because that's what it's designed for. It's a little bit stretchable and it's got a very high tensile strength, which tensile means tension. And that's exactly the force that is on that now. So originally the annulus fibrosus in its resting state was kind of straight like that, and now it's become curved. And as you know, the shortest distance between any 2 points is a straight line, and so a curved line is always longer than a straight line between the same two endpoints. So this now has got longer, or to say that another way, it has stretched. So it's stretched, it's being pulled apart. So it's like it's not being ripped or anything, but it's being pulled, you know, from its two ends are being pulled apart. And so this is stretching and it is now pulling on the ends. Okay, it is pulling on the bone. It is creating a tensile force on that bone. It is pulling this part of bone right here and this part of bone right here where the annulus fibrosus blends into the bone is being pulled. Okay, those two bits of bone are being pulled because the annulus fibrosus is under tension. Okay, it's under tension. It got longer. Okay, it got longer because it is now a curved line instead of a straight line. And so that tension now is, it's pushed out in all directions and that pulls on the ends and causes this tensile force on the end plate. So in compression, in neutral, when the vertebrae are virtually kind of stacked on each other like they are, when we have this compressive force, okay, that is a compressive force on the annulus fibrosus, that is converted into a tensile force, a stretching force, okay, on the a compressive force on the nucleus, my apologies, is converted into a tensile force on the annulus. And the annulus then in turn exerts a tensile force here on the end plate. And it is possible that under very high levels of compression in neutral spine, this end plate can avulse. And to avulse simply means it kind of cracks off, and pulls, a bit of it kind of cracks off and comes off. And I've got some photos of that, but I'm sorry I can't show them to you because they're in a research paper. It'll take me too long to dig it out. But that is the short version, well, actually the quite long version of what happens when you avulse an end plate, and the way that compressive forces on a neutral spine are converted into tensile forces on the annulus of the disc, and that can cause avulsion. So great question, Magali, and you had it exactly right. Danny Bell DM'd me on Insta and said, "Hey Raph, hope you're keeping well. I'm loving the blog posts with all the questions, and I have just a question for your AMA blog. I'm currently in the UK pre-COVID working with a lot of post-hip replacement clients. Over here it seems to be very common that their orthopedic doctor and physio tells them to never bend past 90 degrees at the hip again post-op. Not just in post-surgery rehab, but ever, as they can dislocate the hip. I'd never heard that before in Australia with any of my post-hip operation clients, so I guess I'm wondering what current guidelines are for post-hip replacements in terms of exercise or range of motion they should or shouldn't do, and whether this is a standard thing, short-term and long-term, for them to be not able to bend past 90 degrees at the hip." Hey, Danny. Great question. So I spent quite a lot of time on Google Scholar on this one, and I looked at three things. I looked at risk factors for dislocation after total hip arthroplasty, or replacement is the English name. And I found a bunch of systematic reviews, and I also looked at clinical guidelines or exercise guidelines for rehabilitation after total hip replacement. And I didn't find much there. There's not much literature on that. There's just research has not been done. And basically what I found was a bunch of studies and reviews saying there's not enough research. We need some good quality research in this area. So the systematic reviews on risk for dislocation after total hip replacement essentially found that there are kind of layers of risk. And let's see if I can bring one up here and show you. So here's one I found: risk factors for dislocating after primary total hip replacements, a systematic review and meta-analysis of 125 studies involving approximately 5 million hip replacements. So that's got some good statistical power. And what they found was it's multifactorial. So there are some socio-demographic characteristics and BMI characteristics. So people with higher BMI, certain lifestyle factors, age, etc., ethnic background, all are, increase or decrease the risk. And you can see here this plot, dots to the left of the line here indicate a reduced risk, and dots to the right of the line indicate an increased risk. So you can see that, for instance, high BMI is a very big increased risk, whereas Asians, for whatever reason, compared to Caucasians, have a fairly significantly decreased risk. So there are those socio-demographic factors, and then there are also these other factors which are association with medical surgical history and also the surgical approach. So when they do surgery for total hip replacement, there are multiple different ways they can do it. So for instance, they can go in at the back, they can make the incision at the back of the hip, in the buttock, or they can make it in the front of the hip, through the hip flexors, or they can go kind of to the front or side, or they can go totally to the side. So there are lots of different surgical approaches that they can use to do the surgery, and they have quite different risk profiles. So you can see these dots here kind of moving, indicating, again, decreased risk on the left side and increased risk on the right side of the line. And so you can see that all of these these are all surgical approaches here. They have very different risk profiles to them. So, that's something that I found there. And then I looked in vain to find any kind of exercise guidelines, clinical guidelines, rehabilitation guidelines. I did find a few things, but basically all they said was, let's have a look at what they said. Here we are. Algorithm of physical therapy exercises following total hip arthroplasty. Exercises were divided, blah, blah, blah. At a later stage of rehabilitation, marching and walking, as well as cycle ergometer training, were included. So that's for whatever that's worth. Agreements and disagreements in exercise therapy prescriptions after hip replacements. And what this one basically found was that people disagree with the exercise prescriptions following total hip replacement. So, surgeons tell them, here's what to do, and the exercise professionals disagree, and these are rehabilitation professionals too. I found this Dutch guideline on total hip prosthesis from 2011, so it's a few years old. But this basically goes, it's not just about exercise, it's about the whole process. And so what they found here was, what is the preferred type of prosthesis? What sort of bearings should you use? Should we resurface it? What's the preferred surgical approach? Should we do, minimally invasive procedures or conventional approaches with a bigger incision? What's the preferred method to present thromboembolic complications, so blood clotting? Blah, 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 infection, antibiotic-loaded bone cement, air handling systems. So a lot of stuff that we're not particularly interested in as exercise professional. Anesthetic, what's the value of physiotherapy? Physiotherapy after total hip replacement is effective for recovery of strength, physical function and stability. Physiotherapy before total hip replacement is not effective for recovery of physical function and reduction of pain. Clinical pathways in total hip replacement are cost effective, while functional outcomes and complications are comparable. So is there a need for routine follow-up? And then that's it. And the supplemental material is just a list of all their sources. So basically that doesn't tell us anything useful. Then we have variation in rehabilitation setting after uncomplicated total knee or hip arthroplasty, a call for evidence-based guidelines. So this is a hint what's happening here is they're going to basically say development and implementation of evidence-based guidelines may help resolve the evidence practice gap. Addressing unwanted practice variations across the insurance sectors. What they said was that basically practice is driven more by institutional needs than by evidence. Supervised or unsupervised rehabilitation after total hip replacement provides similar improvements for patients. Well, they tell you the outcome of that in the title. Highlights a randomized controlled trial comparing home versus group-based rehabilitation after total hip replacement. There was no difference in outcomes between the groups at any time point up to 26 weeks. For most patients well enough to be discharged from hospital within a week, independent home-based rehabilitation is a viable option. Then rehabilitation after total hip arthroplasty, a systematic review of controlled trials on physical exercise program. So this was the best one I found, and this is from 2009 though, so it's 11 years old at this point. And so what they say, 9 studies were retrieved from Medline and reviewed. Results show that the physical exercise protocols most frequently used after total hip arthroplasty in the early postoperative phase are neither supported nor denied by clinical controlled trials, or in other words, more evidence, please. Convincing evidence for the effectiveness of single interventions in addition to usual exercise programs exists for each of the 3 following options. Treadmill training with partial body weight support. So in other words, you might have some kind of suspension system that kind of takes, holds you, strapped to the ceiling basically. So only part of your body weight goes on the leg. This is early rehab. Unilateral resistance training of the quadriceps muscle on the operated side. So, one leg knee extension sort of thing. And arm interval exercise with an arm ergometer. So that's in the first, few weeks after surgery. In the late postoperative phase, that's more than 8 weeks post-surgery, exercise programs consistently improve both impairment and ability to function. Weight-bearing exercises with hip abductor, so that's the muscles on the outside of your hip, your glute medius and your glute maximus, your glute minimus, specific eccentric strengthening may be the crucial component in the late phase protocols. So that is, essentially working the abductor muscles as you adduct the leg. So examples of that would be if you're on a reformer, a side splits on a heavy spring, or doing stuff like working on with a band around your knees, and working the the eccentric, or the bringing the legs together part of that. Substantial limitations were found in the 9 studies, including small sample size, patient selection, heterogeneity of outcome assessments, and potential sources of variability not investigated. Despite limitations, we conclude that 3 main suggestions emerged from controlled trials on physical exercise after total hip arthroplasty. Early post-operative protocols should include additive interventions whose effectiveness has been shown. Late post-operative programs are useful and should comprise weight-bearing exercises with hip abductor eccentric strengthening. All right, so that's the best I could find in terms of exercise guidelines, and I really did have a pretty good look. And then here's what I found on Physiopedia. So this is physiopedia.com, total hip replacement. Precautions and contraindications for people who had a posterior approach surgery: no combination of the following hip movements on the operated side: flexion 90 degrees, internal rotation past neutral, adduction past midline. Now, and then anterior approach. Hip replacements following this surgical approach is generally more stable. No specific ranges are currently linked to the precaution movements, as surgeon preference should also be taken into account. Patients are encouraged to avoid A, excessive ranges, and B, combinations of the following hip movements on the operated side: extension, abduction, external rotation. So that's what that says, but it's not cited. It's not referenced. There's no reference there. Where do they get that information from? I don't know. So what I would say, the only avenue I didn't look at in my research, so I've looked at all the scientific literature, but I'd suggest, what you could do if you really wanted to take it a step further would be look at the different brands of hip prosthesis. Like, they've got to be a dozen or 100 different brands of actual artificial hip. And if you go to the manufacturer's website and look at the operating instructions, like the user's manual, it might say, on some of the specific prosthetics, they might have contraindications for those particular movements. So that is the best I can do for you, Danny. I'm sorry. Really, I can't see where they necessarily would have got that from. I mean, they got it from Physiopedia, obviously, but I'm not sure where Physiopedia got it from. So, yeah. But given that there really isn't any evidence or guidelines, and that's what Physiopedia is saying, I would think just from a medico-legal standpoint, you should probably work within the Physiopedia recommendations, even though they seem to be based on nothing but a puff of thin air and pixie dust. Yeah, so there you go. Hope that helps. Megan asks, she says, "Hi, Raphael. I'm looking forward to another lecture today. I'm not sure whether you'll be covering body assisting today. I find this a bit tricky to consider for a fitness class. I understand that Pilates is coming out of a historical physiotherapy perspective, and that the research says that clients want it. But the videos are a lot to consider if there is a male instructor in a female class. I'm thinking the course probably should cover this more specifically. Anyway, I'm enjoying the course, so thanks, Megan." Well, thank you, Megan. Glad you're enjoying it. And good point. I guess this is more of a subjective point, so I'm not really necessarily going to offer you any concrete answers. My personal experience as a male instructor in a almost, completely female class situation is I always, when I was teaching in person, always gave hands-on with clients. I was very careful about how I did it, but I never had any complaints. I'm never aware that anyone had a problem with it, and a lot of people told me that they appreciate it. And so I think what I've got to say about that is, research does tell us that people appreciate it, and at the same time, there is a way of doing it, I think, that makes it feel safe and caring for the person, and not kind of weird and gropey. And I think if you think about, how if you go to the doctor or the physiotherapist or the osteopath or, some other kind of health professional who touches you, well, they touch you in a very particular sort of way. Like they touch you in a way that is if the doctor is, testing your reflexes or looking in your ear or whatever, like they have or the physio is, moving your arm around or whatever. They have a very particular way of touching, which I think is they have a firm and definite way of touching. So like when they pick up your arm or your leg or your back or your shoulder or your foot or whatever, they move it a certain way. Like it's not like, excessively forceful, but it's very firm and clear, as in I'm moving your arm to here. It's not kind of like spider fingers on your arm go. So I think there's a firm, clear directive component, and that communicates a professional competence, and also it's a professional touch. It's I'm not touching you for my pleasure. I'm touching you to communicate something to you that your leg needs to be here. So I think that firm, clear, directive sort of nature of the touch is, I think, very, very important. And then there are just a few, and that also bespeaks confidence, right? So if you, firmly, clearly direct their arm to a certain place or their shoulder to a certain place or whatever, that bespeaks your confidence. And I think confidence, is catching, it's communicable, just like fear is highly catching. So, so there's that. And then the second thing I think is just something mechanical about, where you touch and how you place your hands and your fingers. So for instance, as a man, but I think for women as well, when touching somebody's shoulder, a client's shoulder, it's kind of hard for me, but you don't have your fingers pointing towards their breast, right? You touch them you rotate your hand so your fingers are pointing away from their breast, so that it's very clear that it's your intention to not touch their breast, right? So that would be something like generally I don't like touching people on the tummy. It's my perception, my experience, that a lot of people don't feel comfortable having their tummies touched, and particularly people who are overweight and might feel self-conscious about their tummy. So I just like to not go there. Again, if touching someone on the hip, don't have your fingers facing inwards, touch it with your fingers facing outwards. So it's very clear to the person from the way that you touch them that you've got this firm, clear, directive touch, and your fingers are facing well away from any kind of, danger zones. And then you just, move them to whatever position, firmly and clearly and confidently, but not with excessive force. So I think those are two things. And then the final thing I think is just informing them beforehand. And particularly if somebody can't see you. So for instance, if they're lying on their tummy and they can't, or they're facing one way and you're behind them, they can't see you coming. I think it's crucial to inform them. And here's where I think you have options as well. So, my choice is I just generally inform people, say, hey, hey, Megan, I'm just going to give you a little assist on your ribs here or your shoulder or your ankle or whatever to help you find a better shape in this exercise. So I just say that before I touch. And that I feel gives the client, one, lets them know what's going to happen so they don't get a surprise, and two, gives them the opportunity to, flinch or blanch or nod or whatever, so it's kind of tacitly asking for permission, but it's not overt, it's not explicitly asking for permission. And so the other thing you could do is explicitly ask for permission. Hey, Megan, is it okay if I give you an assist here on your ribs to help you find a better place in better shape in this exercise, blah, blah, blah. So, and now I think that's personal preference, of the instructor. Do you inform or do you request permission? And that might also be guided by, your knowledge of your clients and the protocols at the studio and whatever else it might be. The only time I would not touch someone would be one, if that person was wearing some kind of burqa or hijab or something and obviously was a Muslim, in which case, I wouldn't touch them. Or if they'd requested me not to. So, I hope that helps. That's my personal perspective. It's not the law. It's not a rule, but that's what I reckon. Bridget says, hey, Raf, wasn't sure where to put my questions. Well, you put them in the right place. If running on hard surfaces, e.g. footpath, is good for building bone strength, how do you reconcile that with shin splints having a high prevalence when running on hard surfaces, or is this just a misconception? Commonly, I've heard treatment for shin splints may be to not run on hard surfaces. Thanks very much for your work. The diploma is changing things for my learning and job possibilities to a whole new level. I'm absolutely loving it. Cheers, Bridget. Well, thank you very much, Bridget. So I'm going to put that together with another question, which came from Valida. And Valida, I hope I have pronounced your name correctly. If not, please message me and let me know how to pronounce it properly. Because Valida's question is about the same thing. And she says, I was just in your lecture and have a question. Didn't ask it there because we were running late. This is about injuries. I'm doing my practice teaching with a friend who has had 3 leg surgeries in the last 2 years. He snapped his leg just under his knee 2 years ago, then needed another surgery to remove the plates and then another one because there was an extra bone growing. Since then, he has lots of issues with his shins. Whenever he runs, his shins hurt, especially if it's more than 8 kilometres. He can't really stop running because he has to for his job. I'd say he runs around 30 to 35 kilometres a week and one day a week, 12 to 16 kilometres. After that day, his shins are very sore and hurt for a few days. He sees a physio all the time. The physio has tried needling, icing, massages, but nothing works. Do you think there's something he can do to fix this problem? Or will this only stop when he stops running? If he has a big break from running, would this get better? Does he have shin splints? Thank you. So, I don't know if he has shin splints because I'm not able to diagnose based on the information that you've given me, and also I can't diagnose. But let's assume that he may have shin splints. He's got shin pain anyway. So basically what I found was, let's see what I found. So I did a bunch of searches to do with running-related injuries, to do with medial tibial stress syndrome, and to do with shin splints and stress fractures, and basically all of these things glommed into one. The factors that seem to be risk factors and protective are pretty much the same for all of them. So here's what we found. Biomechanical risk factors. Conclusions. Current prospective evidence relating biomechanical variables to RRI, that's running-related injury, risk is sparse and inconsistent, with findings largely dependent on the population and injuries being studied. Future research is needed to confirm these biomechanical risk factors. So, all right, so that systematic review from 2019 said not enough research and we need to know more. Then we have this one, risk factors associated with medial tibial stress syndrome in runners, a systematic review and meta-analysis from 2013. What did they find? Conclusion, female gender, previous history of medial tibial stress syndrome, fewer years of running experience, orthotic use, increased body mass index, increased navicular drop, that is a bone on the inside of your arch. So if you have it's not flattened arches, it's like the navicular bone itself being lower. And increased external rotation hip range of motion in males are all significantly associated with increased risk of developing medial tibial stress syndrome. Future studies should analyse males and females separately because risk factors vary by gender. So there you go. Incidence, risk factors and prevention of running-related injuries in long-distance running, a systematic review from 2010. What they found was most common injuries sustained by long-distance runners was found to be Achilles tendinopathy, iliotibial friction syndrome, and medial tibial stress syndrome, or MTSS. Most common risk factors are age, running history, and injury history. The only significant measure for runners was the use of orthoses in the prevention of medial tibial stress syndrome and stress fractures. Most of the suggested preventing strategies in running lack convincing evidence of non-randomized clinical trials or have not yet been investigated. Therefore, suggestions for prevention and future research were made. All right. A systematic review of interventions to prevent lower limb soft tissue running injuries. From the year escapes me. Anyway, it was sometime in the last 10 years. And from the British Medical Journal, conclusions, this review provides evidence for the effectiveness of the modification of training schedules in reducing lower limb and soft tissue running injuries. More studies were required to quantify the optimal training loads and confirm that knee braces can prevent knee pain. It is important to note that the studies included in this review had few female participants, therefore the results may not be generalizable. So what they says here is exposure to high training load, duration, frequency, or running distance increases the risk of an injury. And thus modification of the training schedule can reduce the incidence of injury. The effectiveness of stretching exercises and insoles is the prevention of lower extremity soft tissue injuries caused by running is not known. There you go. So don't bother stretching, but maybe reducing the kilometres if possible. What's this one? What are the main risk factors for running-related injuries? From May 2014. Conclusions. The main risk factor identified in this review was previous injury in the last 12 months, although many risk factors have been investigated in the literature. Relatively few prospective studies were identified in this review, reducing the overall ability to detect risk factors. This highlights the need for more well-designed prospective studies to fully appreciate the risk factors associated with running. Then we have this one, injuries in runners, a systematic review on risk factors and sex differences. Let's see if we can make that bigger. Yes, we can. All right, conclusions. Previous injury and use of orthotics or inserts are risk factors for running injuries. There appeared to be differences in the risk profile for men and women, but as few studies presented results for men and women separately, the results should be interpreted with caution. Further research should attempt to minimise the methodological bias by paying attention to recall bias for running injuries, follow-up time, and the participation rate for the identified target group. So all I know is orthotics are a risk factor for running injury, and previous injury is a risk factor. Incidence and determinants of lower extremity running injuries in long-distance runners, a systematic review from when? Don't know, sorry. 2000 is it 2006 or is that just the DOI? Anyway, yes, 2006. All right. What they found. The incidence of lower extremity running injuries range from 19 to 80%. The predominant side of these injuries was the knee. There was strong evidence that a long training distance per week in male runners and a history of previous injury were risk factors for injuries, and that an increase in training distance per week was a protective factor for knee injuries, which kind of sounds weird to me because if you're doing a long distance, that's a risk factor, but if you increase the distance, that's a protective factor. So probably have to read the full text of that one to understand what they mean by that. So basically, that's what I found in terms of the risk factors for injury. So based on that, I would say, reducing running kilometres per week probably would help. But I also found some stuff on gait retraining. And I'm sorry, my EndNote is still syncing at the moment, so I don't have access to those on this screen that I can show you. But what I found was pretty consistent that gait retraining interventions combined with load management education are pretty effective for reducing running injury, lower leg running injuries. And so what they do in these, and including medial tibial stress syndrome, and so what they do in these interventions is they basically give people the instruction to run softly. So make less noise when you land. And in order to make less noise when you land, you have to land with, generally people transition from a heel strike to either a midfoot strike where the whole foot lands together or a forefoot strike. And then they also land with their knees a little more bent, and sometimes their hips a little more bent as well, so that they use their muscles to absorb the shock of impact rather than it just landing on the heels and all going through the bones. So it's not necessarily, to be clear, the instruction was land quietly, land softly. So it's not an instruction to adopt a forefoot strike or a midfoot strike or anything. These gait interventions didn't tell people the specifics of how to run. They just told them the result of try and make less noise when you run. Try and run softly. And so these interventions have been effective, and they're even more effective when the person has feedback. So sometimes they use treadmills with pressure sensors on them and things like that, and that displays for the person how much pressure they ran with. But I think just running on a hard surface and listening to the noise when you run and trying to make it as little as possible is probably good. But just bear in mind that, changing your running style, like if you're running 35 kilometers a week and you change your running style, you could get like major DOMS, delayed onset muscle soreness. And so what I'd recommend would be change it a little bit as a time. So I would recommend, maybe the first 500 meters of running each day, do it in the new way, and then the rest of it just run how you normally run, and then do that for a couple of weeks, and then up it to a kilometre, that you do the new way, like as in running as softly as possible. And if at all possible, I would combine that with reducing weekly kilometres, at least temporarily, and then gradually build it back up based on as symptoms permit with the new running style. Now, as to your question, Bridget, about running on hard surfaces, in all my studies, I found one that found an increased risk for women but not men when running on concrete surfaces. But all of the rest of them basically didn't find that the surface was related to the risk of injury. It's really previous risk of injury, previous history of injury, age, and weekly kilometres is really and BMI also. So your weight are basically the risk factors. So I hope that helps. And Velita has one more question. She says, it's hard to get a job as a Pilates instructor. Is it hard to get a job as a Pilates instructor when you're pregnant? I'm only 10 weeks pregnant, but by the time the studios will open again, it will be more and maybe even obvious. And then after giving birth and staying at home for a few months, would anyone hire a Pilates instructor without any experience? All right, so two questions there. How do you get it? Will anyone hire a pregnant Pilates instructor? And two, will anyone hire a Pilates instructor without any experience? Well, yes, people hiring Pilates instructors without any experience all the time, because otherwise no new graduates would ever get a job. And something like 98% of our graduates go on to either full-time work or further study after the course in Pilates. So yes, absolutely, people get hired without any experience. So that is not something you need to worry about. Will people hire a pregnant Pilates instructor? Well, it's kind of a touchy subject, both ethically and legally, because you're not allowed to legally in Australia, you're not allowed to be biased or refuse someone employment based on their pregnancy status. But for employers, it's a very real consideration that when they put on a new team member, it takes time and effort and probably money to train that person up in the way that they, you like doing things at your workplace and whatever, indoctrinate them in the workplace procedures and culture and buy them their T-shirt with the logo on it or, whatever other things they get given, give them all the passwords to the websites, et cetera. There's effort and, time in that, writing the bios, taking photos, putting on the timetable, all that. And then the clients get to know that person and have an investment. And then if you know that in 20 weeks or 30 weeks, that person's going to disappear for 6 months, I think that definitely does play for most employers as a risk or essentially a black mark against you in terms of your desire, how desirable of an employee you are. But at the same time, they're not allowed to, legally consider that. So it's kind of it's a tough situation for the employer. It's a tough situation for you. I absolutely think your best bet is to be upfront, because they're going to find out anyway. And if they find out later and they knew that you knew at this time, and they do the math and go, hold on, you were 15 weeks pregnant when you were employed here. Why didn't you tell us? So you absolutely should tell them. I think if you go to a family-friendly studio, somewhere where the studio owner is a parent, then you're more likely, I think, to find employment. We have 18 people on our team, 16 of them are women. 3 of them have had babies in the last few years, and it's kind of an inconvenience, but then they come back and it's super awesome having them back, and they're amazing people to work with, so it's worth it. So I hope that helps. Thomas asks, I got an email that said, ask me anything. So here it is, mate. Do ice baths work at all, or are they just a load of shit? Well, short answer, they're just a load of shit. But slightly longer answer, they work a tiny bit to reduce discomfort. So basically people have ice baths, and the high-class word they use in the literature is called cryotherapy, or cold water immersion. And it basically a lot of athletes do it. It's super common in the elite athlete world to use ice baths after training to aid recovery. And what the literature shows, there's quite a large literature on this now, is that ice baths do not make any detectable difference to any biomechanical or biochemical markers of recovery, and they do not make a difference to the speed of recovery or performance. What they do make a difference for is delayed onset muscle soreness. They seem to reduce it a bit, and they seem to reduce perceived fatigue in the athlete. So the athletes, after they take the ice baths, they say they feel fresher and have less pain, but their recovery is not quicker in terms of their return to strength, speed, etc. is not better as a result of the ice baths. And if you're in an ice bath for more than 10 minutes, it can actually reduce muscle hypertrophy. So when you exercise, one of the effects is your muscles get bigger and stronger, and ice baths blunts that effect of exercise. So I would say if you're desperate to avoid DOMS, maybe have an ice bath. But don't stay in more than 10 minutes. But apart from that, they're just basically a big old waste of time. Ice baths. Carmen says, hey, Raf, would love a how to set up hints on lighting, microphones, etc. to set up an at-home business. Something to think about for the future, or even professionally now. I think, I don't see myself as the world's biggest expert on this, but I've learned a few things in our transition to 100% online delivery. And so I guess the first thing I would say is don't let lack of technology be a blocker for you. Start with what you got, right? So if you've got a phone and an internet connection, go do it. Do it now. And the guidelines that we've given you as part of your course for how to set up your space, in terms of like, don't have the camera, you don't have your back to a window, how far, how big the space should be, be like 1.8 meters away from the camera, etc. If you're teaching Pilates, have the camera, at the middle of the mat facing sideways towards you at the height that you will be at, so not looking down on you necessarily. So those things. Then, the next level I think would be to get yourself a microphone. And you can get a cheap microphone, like what I would recommend is called a lavalier microphone. And that's just one that kind of clips onto the neck of your garment. And you can get a lavalier microphone that with a wireless sort of body pack that then transmits to your phone and your phone or your laptop or whatever. And so one of those would set you back, I think somewhere in the order of like $200, maybe $250. And the one I would recommend at an entry level would be the Rode Go mic. Rode is RODE, and the mic is called the Go Plus or the Go Mic Plus or something like that. And then the next level up above that, I don't really think you need the next level up above that. I think that's one will last you for years and it'll be awesome. So that's what I would recommend is the Rode Go Plus or something with a lavalier microphone. That's one that clips onto your lapel. And so that will make the biggest difference because you'll get a pretty decent video quality just straight off your phone. Obviously, you'll need some kind of stand or tripod or something to position your phone. So that's be thing number one. But assuming you've got that, the next thing I would buy would be a wireless mic to get you decent sound. And the next thing I would buy after that would be probably 2 lights. And the light, I think you can get lighting kits is what I would recommend. So a lighting kit would be like the light plus the stand plus the charger, like basically everything you need. And so you can buy a kit of 1 light or 2 lights or 3 lights. I'd recommend probably 2. And you have 2 main lights, and one is called your key and one is called your fill. And so basically, the way I've got it set up here for filming here is I've got my camera straight in front of me and I've got my key light off at about 45-degree angle, and that is looking slightly down on me. And the reason I don't have it straight behind the camera is because I'll get glare off my glasses, or even if I didn't have glasses, you would see little rings of light on my irises there. So you have your key light off to the side. And then you have your fill light exactly the same angle. So 45 degrees for the key light and then 45 degrees the other way. My fill light is back here and it's twice as far away so that it's half as bright. Okay. I'm not sure the exact distances, but it's significantly further away. So it's much less bright. And so that way there's not a uniform light on you. It's kind of like, it looks a bit more realistic, like in, there's kind of bits of light and shade. So that's what I would recommend. First purchase is, if you don't have one, something to hold your phone or laptop so it can see you properly. Like the right angle. The second thing would be a Rode Go Plus mic with an additional microphone. So the Rode Go Plus is the transmitter and receiver, it's the wireless thingy. And then the lavalier is a microphone with a little cord that plugs into the transmitter. And then the next thing would be a pair of lights. The ones I'm using here are LED ones. They cost something around $200, $250. And don't get battery operated ones. Hint, buy ones that can work on a chart, like on a wall plug, ones that you plug into the power, and make sure that you check that when you buy lights that they're not battery operated. Because if you're running like 2 or 3 classes back to back, you're going to run out of batteries. Most of them, the battery only lasts an hour, 2 hours. So buy ones that you can just leave plugged into the wall, and charging the batteries becomes a pain up the backside. And then finally, if you want to sort of go to the next level, now what I've just described to you, I reckon is an awesome setup that'll get you a really good picture and audio quality. If you're careful and clever about where you set up. So in other words, where the light is coming from in the room, you don't have a light source behind you or whatever. Now I've got a window behind me here, but I've got the blind down and I've got really good lights here. So that's not an issue. But if you don't have lights and you have a window behind you, it looks bloody horrible. Like, give you an example. That's with my lights turned off. So that kind of sucks, right? All right. So, and then, if once you've got that set up, I reckon that's a great setup, and that's probably all you need. But if you really want to next level it, the next thing I would say, and that's the next thing I would say is get a decent mirrorless or DSLR camera that you can use as a webcam. And a decent one. Now, that is the next level thing because you have to do some research and stuff. The ones that we use is called a Sony Alpha A6400. So all of our trainers have the same camera. It's a mirrorless camera. It comes with a lens kit, and they're about $1,900 in Australia as of now. But then, of course, you need a tripod for that, which is another $300-$400 for a decent tripod. You need a few cables and blah, blah, blah. So that ends up being like almost a $2,500 investment, but you get really good video quality. So if you enjoy the video quality that we provide, that's what we use. But I don't think you need to go that far. I think just your phone, if you've got a phone that's manufactured in the last 3-4 years, plus a decent lavalier, like a $50 lavalier mic plus a wireless transmitter, plus $250 worth of lights, you'll get a brilliant setup. Last ones. Andrea said, and this is left over from last week, apologies, Andrea, I missed it. Andrea said, another of my clients has recently had a hysterectomy and has been thrown into early menopause. She now suffers from sore joints. Do you know what would be the reason for this? Well, I don't know what's the reason for that, but I looked at some reviews of symptoms of menopause, and lo and behold, sore joints definitely is one of them. So it seems to be, people get sore joints and sore back as well. And it seems to be very much related to, other symptoms like hot flushes and, whatever other symptoms people get. And so it's just one of them things. And it seems to pass eventually. I would just say, sorry, that kind of sucks, but you just got to ride it out because I don't think we have a really good treatment. Hormone replacement therapy seems to help some people, but that has its downsides as well, and it's a pretty significant thing to undertake for sore joints. So I'm sorry I can't really help with that, but it does seem to be definitely related to menopause for a lot of women. And finally, Andrea asks, what is a good exercise for strengthening neck muscles for someone who suffers chronic neck pain? I hope I haven't gone overboard with questions. Thanks again, Raf. P.S. The weekly anatomy lessons are just the bomb. Andrea, thank you. I put together a little compendium of neck exercises. So let's see if I can find them and share them for you. Where did I put them? I put them here under neck. Yeah. Here they are. Let me just get those in the local. All right. So here we have them. All right, so here are some options. Get your jolly flex band out, and you can do these either isometric, as in like you pull on the band with your arm and you just keep your head still, or you can do them as concentric eccentric. So you do side bends with your head or turn your head against the force of the band. You can do it with just your hand. You don't even have to have a band. You just push your hand against your head and you push your head against your hand, and bada bing, bada boom. And you could do that with isometric, as in not moving, or you could do it concentric, eccentric, as in moving. You could do it leaning against a wall with a towel or a ball. You can do the front, the back, and the sides. And you can do that again, concentric, eccentric, or isometric. I think the moving one would be easier with the ball, but there you go. The other thing is you can use a power band. So this guy here is holding it. I actually do neck exercises and I use a power band. I use a much thicker one than that. Not because I've got amazing neck strength, but just because I find it comfortable on my forehead. It doesn't dig in. And I actually tie it off to, I've got a squat rack in my basement. I'm lucky. but you could tie it off onto a Cadillac or a doorknob or any old a washing line, if you've got stall bars, you can tie it off onto that. And then just, you can do the sides, the back and the front. I love the power band option myself. Here's another look at the wall ball scenario. And finally, you can buy special cradles, and I don't know the exact price, but my guess would be something like that would probably be in the, $50 to $100 price bracket. And you can attach, as you can see here, a weight plate to it. You could also attach a spring to it, and then attach it to a Cadillac or attach a flex band to it, stand on the flex band and pull it. And then finally, there's also you can just work the shoulders because, of course, well, maybe of course, and maybe not of course for you, depending on your knowledge of anatomy, but basically a large number of the muscles that control the neck are also shoulder muscles. So the upper trapezius, the rhomboids, the levator scapulae, the sternocleidomastoids, the scalenes, all of these muscles are muscles which cross both the shoulder girdle and the neck. So a lot of times, anytime you work your arms, particularly when you're lifting your arms up, you're also, the muscles you're working are shoulder muscles / neck muscles. They're both. And there's pretty good research supporting just doing, plain old vanilla lateral raises with a flex band, like literally this exact movement, that for people with chronic neck pain, and has shown really good results. And what they did in the study that I'm thinking of is they did 2 minutes each day of this exercise. And 2 minutes is quite a bit. You should get some good burning in your shoulders after that. So those would be my suggestions. My personal favorite here is the power band. I don't like to hold it in my hand because I'm lazy. I like to tie it onto something and then I just lean on it. But I love all of these ones. I think they're really clever and you can do them with next to no tools. So there you go. That is chronic neck strengthening, which has been shown by quite a lot of research to be very effective for chronic neck pain. You got sore neck, strengthen it. So there you go. That is Ask Me Anything for today. I hope you've enjoyed it. I hope you're loving life wherever you are. And if you have questions, I'd love to hear them. You can email me, Raphael.b, that's RAPHAEL.b, at breathe with an E, breathe.edu.au. Or if you're on Slack with me, you can ping me at Raphael_BE, or you can just tag me on social media. So I'd love to hear from you, and I look forward to the next time we get to chat. I hope you have a great week. See ya.